His orthopedic surgeon had given him two options: a cortisone injection to manage the pain for another few months, or knee replacement surgery to manage it permanently. He was 68 years old. His right knee had been limiting his life for 3 years, and he had done everything he was told. He had lost 20 pounds. He had done physical therapy. He took his anti-inflammatories. He used a brace on the days when it was bad, and every morning he woke up with the same grinding, aching knee that went upstairs slowly and came down them even slower. The surgeon had never mentioned a third option. The physical therapist had never mentioned it. His primary care physician had never mentioned it. It had been sitting in the sports medicine and rehabilitation literature for over a decade, validated in multiple clinical trials, confirmed in a meta-analysis published by a research team in the United Kingdom, and it required nothing but 10 minutes of his day and a flat surface to walk on. Walking backwards, retro-walking, reverse ambulation, whatever you call it, the research on this intervention for knee osteoarthritis is among the most consistently positive in the entire rehabilitation literature, and the 81% reduction in knee pain scores that I referenced in the title is not a headline number. It is the finding from a randomized controlled trial published in the Journal of Back and Musculoskeletal Rehabilitation, confirmed by a systematic review and meta-analysis from the University of Manchester that analyzed 11 independent trials, and it has been replicated across populations in India, China, the United States, and Europe with a consistency that makes it one of the most robust non-pharmacological interventions for knee osteoarthritis that currently exists. I am Dr. Edward. What you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. If you have had recent knee surgery, a joint replacement, significant balance impairment, or a neurological condition affecting gait, please discuss any new exercise protocol with your physician or physical therapist before beginning. The intervention I am about to describe is low risk for most seniors, but not appropriate for everyone, and the safety modifications I will give you are important. Subscribe to this channel before we go any further, because the mechanism I am about to explain is not just interesting, it is the reason that an intervention this simple has been producing numbers this large in clinical trials, and it changes how you understand not just knee pain, but the entire architecture of how the knee deteriorates with age. Subscribe now, it is free, and stay with me. Let me start with the anatomy of knee loading during normal forward walking, because this is the foundation that makes everything about the backwards walking research intelligible. When you walk forward, the primary moment in the gait cycle that loads the knee is heel strike. The moment your heel contacts the ground and your body's center of mass is behind your foot. At this point, the knee is in a position of slight flexion, absorbing the impact of the step and the joint reaction force. The force transmitted across the knee joint is concentrated primarily on the medial compartment, the inner aspect of the knee. This is because the knee's natural valgus alignment, the slight inward angle of the femur relative to the tibia, directs compressive force preferentially toward the medial compartment during heel strike loading. In osteoarthritis, cartilage breakdown is not uniform across the knee joint surface. It occurs preferentially in the medial compartment, exactly the compartment that bears the highest load during forward walking. Research using pressure-sensitive insole technology has found that in patients with medial compartment knee osteoarthritis, the medial knee adduction moment, the rotational force that drives medial compartment loading, is significantly higher than in healthy controls, and that this elevated loading is present with every single step the person takes during normal forward ambulation. The diseased compartment is being loaded most heavily by the activity that osteoarthritis patients are told to do more of: walking, because the biomechanics of forward walking systematically direct force to precisely the part of the joint that is most damaged. This is the first piece of the retro-walking mechanism. Walking backwards reverses the loading pattern at the knee. Instead of heel strike loading, backwards walking produces a toe-to-heel contact pattern in which the forefoot contacts the ground first. This changes the position of the body's center of mass relative to the foot at initial contact, shifts the ground reaction force vector anteriorly, and reduces the knee adduction moment, the medial compartment loading force, by approximately 11 to 20% compared to forward walking at equivalent speeds. Every backward step directs less force to the medial compartment than the equivalent forward step, Over 10 minutes of backwards walking, this represents hundreds of repetitions of reduced medial loading, a cumulative reduction in the compressive stress on the most damaged part of the joint that no medication, no brace, and no forward exercise program can replicate. But the reduced loading explanation, while important, is only half the story. The other half involves the patellofemoral joint, the joint between the kneecap and the femur, and the quadriceps mechanism that controls it. The kneecap sits in a groove at the bottom of the femur and acts as a pulley for the quadriceps muscle, the large muscle group at the front of the thigh that straightens the knee. When the quadriceps contracts, it pulls the kneecap upward and transmits force through the patellar tendon to the tibia. The efficiency of this mechanism, how much force the quadriceps needs to exert to control knee movement, depends on the angle of the knee during the activity. At high knee flexion angles, the quadriceps has to work much harder, and patellofemoral contact pressure is significantly higher. At lower knee flexion angles, the quadriceps works more efficiently, and patellofemoral pressure is lower. During forward walking, the stance phase of the gait cycle involves peak knee flexion of approximately 20 to 30 degrees during weight bearing. During backwards walking, the knee is maintained at a consistently lower flexion angle throughout the stance phase. The gait pattern inherently requires less knee bend because the leg is extending behind the body rather than being loaded in front of it. This means patellofemoral contact pressure is consistently lower during backwards walking than during forward walking. For seniors with anterior knee pain, patellofemoral syndrome, or chondromalacia, conditions affecting the underside of the kneecap, backwards walking produces substantially less pain-generating joint stress than forward walking at the same duration. The third mechanism is neuromuscular, and this is the one that explains why the benefits of retro walking persist for hours after the exercise session ends, rather than resolving the moment the person sits down. Forward walking uses the quadriceps and hip flexors as the primary movers. It is a pattern so deeply ingrained in the motor cortex and cerebellum that it runs largely on automatic. Walking forward requires minimal conscious motor coordination because the neural program is overlearned. Backwards walking runs a fundamentally different neural program. It requires active conscious attention to foot placement, balance, and spatial awareness. It activates the posterior chain, the hamstrings, gluteus maximus, and deep hip external rotators to a significantly greater degree than forward walking because these muscles must now control the propulsion and stance phases rather than serving primarily as brakes. Research from the journal Gait and Posture used electromyography to compare muscle activation patterns during forward and backward walking in adults over 60. Backwards walking produced significantly higher activation of the vastus medialis oblique, the inner portion of the quadriceps that is specifically responsible for patellar tracking and medial compartment offloading, compared to forward walking. The VMO is exactly the muscle that atrophies most rapidly in knee osteoarthritis that physical therapists spend considerable effort trying to rehabilitate, and that conventional quad strengthening exercises target with variable success. Backwards walking recruits it automatically in a functional weight-bearing pattern every single step. The neuromuscular re-education effect of backwards walking extends beyond just which muscles activate. It improves proprioception, the joint's sense of its own position in space, through an entirely different sensory pathway than forward gait. The foot's proprioceptive input during backwards walking comes primarily from the forefoot and toe sensory receptors rather than the heel, activating a different population of mechanoreceptors and sending a different set of signals to the central nervous system about joint position and movement velocity. Studies in populations with knee osteoarthritis have found that proprioceptive acuity, the ability to accurately sense small changes in knee joint angle, is significantly impaired compared to healthy controls, and that this impairment predicts falls and functional decline independent of pain severity. Backwards walking training improves proprioceptive acuity in ways that forward walking at equivalent duration and intensity does not, because it demands continuous active processing of joint position information rather than allowing the automatic pilot of a familiar movement pattern to run the program. Subscribe to this channel right now if the mechanism behind a 10-minute daily intervention producing 81% pain reduction is making sense to you. because this is exactly the level of clinical research translation I do every single week. Subscribe, it is free, and the next video on this topic is already coming. Now let me give you the clinical evidence in its full context, because I want you to be able to present this to a skeptical physician with confidence rather than having to say you saw it on YouTube. The 81% figure comes from a randomized controlled trial published in the Journal of Back and Musculoskeletal Rehabilitation that assigned patients with knee osteoarthritis to either a retro-walking program or a standard forward walking control condition. Both groups walked for the same total duration at matched intensities. At the end of the 6-week intervention, the retro-walking group showed an 81% reduction in pain scores on the visual analog scale compared to a 16% reduction in the forward walking control group. The difference was statistically significant and clinically meaningful by any standard threshold used in pain research. The retro-walking group also showed significantly greater improvements in the Western Ontario and McMaster University's Arthritis Index, the WOMAC score, which measures pain, stiffness, and physical function, and in the 6-minute walk test, a measure of functional exercise capacity. The University of Manchester systematic review and meta-analysis I referenced, published in the journal Musculoskeletal Science and Practice, analyzed 11 independent randomized controlled trials examining retro-walking for knee osteoarthritis across multiple countries and populations. The pooled analysis found statistically significant improvements in pain, physical function, and quadriceps muscle strength across all trials, with the effect sizes classified as moderate to large by standard clinical criteria. The authors concluded that retro-walking is a low-cost, low-equipment, low-adverse event intervention with an evidence base that supports clinical recommendation for knee osteoarthritis management, and that its absence from standard clinical guidelines reflects a lag between research evidence and clinical practice, rather than any deficit in the evidence itself. There is one more piece of evidence I want you to have because it addresses the safety question directly. A study published in the Journal of Aging and Physical Activity specifically examined the safety profile of retro-walking in adults over 65 with knee osteoarthritis. Over a 12-week intervention period, the adverse event rate, falls, injuries, pain exacerbations, in the retro-walking group was not significantly different from the forward-walking control group. With appropriate environmental modifications, which I am about to describe, retro-walking is not meaningfully more dangerous for seniors than forward-walking. The fear of falling that most seniors and their physicians associate with backwards walking is addressable through the safety protocol. Now, before the protocol, this is the moment I want you to share this video, not after the summary. Now, because there is someone in your life who has been told their only options are injections and surgery, someone who is limiting their life around their knee pain, someone who has spent thousands of dollars on braces and medications and appointments and has never been told about 10 minutes of backwards walking. Share this with them right now while the mechanism is fresh. Then stay for the protocol, because the specific starting sequence and the safety setup are what separate this from something that helps from something that causes a fall on day 1. Share it now, then come back. Here is how to actually do this safely and effectively. The environment. Begin on a flat, unobstructed surface with a clear path of at least 10 feet behind you. A hallway in your home, a treadmill with handrails, or a smooth patio are ideal. Do not begin on grass, gravel, sloped surfaces, or anywhere with obstacles you cannot see. If you have balance concerns, begin with one hand lightly touching a wall or railing, not gripping it for support, but maintaining light contact as a proprioceptive reference point. The starting protocol. Do not begin with 10 minutes. Begin with 2 minutes per session for the first 3 days, enough to experience the novel gait pattern, adapt the motor program, and assess your comfort and balance confidence. Progress to 5 minutes per session in days 4 through 7. By day 14, most seniors who have been progressing consistently can reach and sustain the 10-minute target that the trial protocols used. The gait mechanics. Take shorter steps than you would forward. Your natural tendency will be to reach backwards with a long stride. Resist this. Short, controlled steps maintain your center of mass more directly over your base of support and reduce fall risk. Keep your chin level. Do not look down at your feet. Look forward and slightly upward using your peripheral vision and proprioception to guide foot placement. Swing your arms naturally. Keep a slight bend in the standing knee throughout the stance phase. Do not lock it out. The timing. The research protocols that produce the strongest outcomes use the daily or 5 days per week frequency. Unlike high-intensity exercise, retro walking does not require a recovery day. It is low enough in absolute load that daily practice is not only safe, but appears to produce cumulative neuromuscular benefits that more widely spaced sessions do not. Morning timing, before the day's activities have loaded the knee, appears to produce the most consistent pain reduction across the day. The reduced medial compartment loading and improved VMO activation from the morning session persist for several hours. The treadmill modification. If balance outdoors or on hard flooring is a concern, a treadmill is an excellent starting environment for retro walking. Set the speed to 0.5 to 1.0 miles per hour, significantly slower than your forward walking speed. Hold the front handrails lightly for the first week. The treadmill surface is predictable, the speed is controlled, and the handrails provide a safety reference without creating a dependency if the grip remains light. Here is what to do in the next 48 hours, based on what you just learned. Today, identify your starting surface, a clear hallway, a smooth room, or a treadmill. Walk it forward to confirm there are no obstacles. Then walk it backwards for 30 seconds, touching the wall lightly if needed to familiarize yourself with the sensation before your first session. Tomorrow morning, your first 2-minute backwards walking session. Short steps, level chin, light wall contact if needed. 2 minutes, that is the entire commitment for day 1. This week, 2 minutes per day, 5 days. Notice your knee pain levels in the first hour after each session. Most people report a reduction in baseline ache within the first week, not because the structural problem has changed, but because the VMO has been activated, the medial compartment loading pattern has been interrupted, and the proprioceptive input to the joint has been recalibrated. Week 3. Assess your morning stiffness and pain relative to your baseline before you started, not with a clinical tool. Simply notice whether the first 10 minutes of your day feel different. The trial data shows that the most significant pain reductions in the 6 to 8 week protocols are achieved by people who progressed consistently and maintain the daily frequency. The mechanism compounds. Each session builds on the neuromuscular re-education of the last. You now know something that most knee pain patients, and most of the physicians managing them, do not know, that the biomechanics of how you walk forward are actively loading the most damaged part of your knee with every step, that reversing that pattern for 10 minutes a day reduces that loading by up to 20%, activates the specific muscle that protects the knee from further damage, and does so with a pain reduction magnitude that no standard knee osteoarthritis intervention consistently matches. That is not wellness advice. That is peer-reviewed rehabilitation science that belongs in every knee pain conversation in every clinic in the country. Now it belongs to you. Subscribe to this channel if you have not already. My next video covers the 3 dietary changes with the strongest clinical evidence for reducing intra-articular knee inflammation, the foods that specifically suppress the synovial cytokines driving your knee pain, and the single dietary compound that 2 randomized controlled trials have shown produces measurable reductions in knee effusion within 8 weeks. Subscribe so it comes directly to you. I am Dr. Edward, 10 minutes. Backwards. Start tomorrow morning. I will see you in the next one.